Welcome, everyone, to the Jameel Arts and Health Lab conversation series on arts and health. It is a real pleasure to have you with us here today. Next slide. We have the pleasure today of having a conversation around the latest trends in social prescribing, and I'm joined by three wonderful leaders in this area. Dr. Bogdan Shvajurka is a British physician and the global director and clinical lead of the National Academy for Social Prescribing, founded by the UK Secretary of State for Health. His work has influenced healthcare policy globally, supporting social prescribing in 32 countries and integrating it into university curricula around the world. He's an honorary lecturer at the University College London and holds teaching roles at Imperial College London and Harvard University, earning recognition as one of the UK's top 100 most influential people in health. Dr. Kate Mulligan is the founding scientific director of the Canadian Institute for Social Prescribing, where she builds the research evidence, implementation support, policy structures, and inspiration for social prescribing across Canada. He's also a health geographer and a globally recognized expert in community-led and neighborhood-scale interventions for health and well-being at the University of Toronto. Dr. Mulligan is an advisor and frequent collaborator with global social prescribing leaders, including Social Prescribing USA. And finally, we have Dr. Jill Sonke, who's supported the coordination and curation of today's conversation. Jill is the Director of Research Initiatives in the Center for Arts and Medicine at the University of Florida, Director of National Research and Impact for One Nation, One Project, co-director of the Epi Arts Lab, a National Endowment for the Arts Research Lab in partnership with University College London, Director of the University of Florida Interdisciplinary Research Lab. She's also an affiliated researcher with the Jameel Arts and Health Lab. Dr. Sonke served during the pandemic as a senior advisor to the U.S. Centers for Disease Control and Prevention, Vaccine Confidence and Demand Team on the COVID-19 Vaccine Confidence Task Force, and currently serves on the steering committee of the Jameel Arts and Health Lab as well. Thank you so much, Jill, for your support in coordinating this session. And without much further ado, we're going to pass this over to you, Dr. Bogdan Jurka, to kick us off. And I'll just before you actually begin, just a brief note, a reminder to everyone that we're recording today's conversation, and you're welcome to keep your cameras on or off, and also invite people to write their questions and comments in the chat as we proceed, but we'll be saving all questions to the end for a robust conversation. All right, now I'll pass it over to you, Dr. Jurka.
Thank you very much. Thank you very much for the introductions, and thank you to you, Nisha, and the whole team, and to Jill for organizing such a brilliant session. I'm looking forward to sharing what we've learned from the UK, but also from countries that we've been supporting around the world. So my name is Bogdan. I work as an emergency doctor by background. So that's my day-to-day. So I will bring a bit of a medical perspective just to share a few elements and details there. And I guess the element that I'd like to start with first and foremost is that the grass always seems greener. So you all may know that the UK was the first country to invest in social prescribing as national policy in 2019. And everybody seems to think that it was because it seemed to be an innovation at the time. However, I'd like to just remind you that our healthcare system is more broken than other healthcare systems around the world. And so I just wanted to share some of the sad elements that we see in our healthcare system. And social prescribing came about because things couldn't go as they were, because hospitals and hospital care was no longer enough to support people. And we started thinking about shifting and moving more towards community and home-based care. And so these are some of these statistics that have been coming out lately out of the English healthcare system. We have 1 in 4 young people who have one long-term problem. 33% of teenage girls are actively self-harming in the UK. So that's 1 in 3 teenage girls not thinking about it, but actively self-harming, which is absolutely mind-blowing and shocking. So we are facing also, as you may have seen on TV, a workforce crisis. There's not enough doctors. There's not enough people to tell people what to do. And so the sick care model of telling people what to do and the revolving door that hospitals have become are no longer efficient or effective. And so we had to come up with a different model. And I'd like to believe that that's how social prescribing came about. about. It went from something that would be nice to have to essential to our health and well-being. And we know that we're not the only ones around the world. There's healthcare systems around the world which are struggling for the same purposes and the same reason. We have a crisis in healthcare professionals, a crisis in mental health, loneliness and isolation, and so on and so forth. And social prescribing was developed as an intervention, as a tool. And I'd like to just remind ourselves what it is. This picture presents an oversimplified version of what social prescribing is. It has many shapes and many forms. It doesn't have to look like this, but I'll just keep it like this for the purposes of this webinar, and then we can discuss a bit more in the Q&A session as well. But if you imagine an individual who comes to me, for example, as a healthcare professional, as a doctor, maybe they go to the GP or they go to the emergency department, and they go with what seems to be a biomedical problem, but we soon realize after we've done all of our tests and all of our investigations, it's relevant, and it seems that they don't have a medical problem. They have a social or a psychological problem. So, for example, they may have lost their husband a year ago. They're not leaving house at all. They have no friends, no relatives. They feel low. They feel lonely. They feel isolated. In that case, for such individuals, we know that prescribing yet another pill or over medicalizing them and going down the medical path will do nothing for them. And the healthcare professionals in the hospital environment, we don't have time to actually dig deep to what truly matters to the individual. So that's where the social prescribers, also in the UK called link workers or community connectors around the world, or health advocates, there's various terms that exist around the world. The social prescriber exists there to give people time. In fact, it's the only role in the world, in the whole wide world, that's been employed by the government to provide people time to actually sit down with the individual to understand what is it that truly matters to them, as opposed to what we think is the matter with them. What's the diagnosis, which is what myself and many of my doctor colleagues would usually focus on. Once they spend that time with the individual and they build trust with them, they understand what is it that makes them tick, and they then send them to the local community. They connect them to an activity that resonates with them. So, for example, if somebody used to do salsa dancing when they were young, or if they used to do gardening, or if they are in need of practical financial support, they would be connected with those services. But I think what's very important to point out, that the reason I have this slide all the time, is that we are big believers that the intervention is both the activity, so the gardening itself, the art class, the music therapy session, but we also believe that the session with the community connector, with a link worker, with a social prescriber is also part of the intervention. And that's very, very important, because these individuals would spend between 1 to 5 hours to build trust with that person. And let's not forget that trust is a social determinant of health. People would not listen to my advice. Sometimes in clinics, I can tell them to go gardening. I can tell them to go singing. I can tell them to stop smoking. They will not do that unless they trust me, unless they know why they're doing it, and unless it's relevant to their why. And this is why we are big believers that this middle part is where the magic happens, is that trust that people build. And social prescribing link workers are often from the same demographic as the people that we see. We believe that social prescribing works best for those who need it most, especially those from more impoverished communities or less served communities around the UK. So these link workers will be speaking the language of the local community. They will be able to get over the barriers that I may not be able to get as a healthcare professional. And I'm swiftly moving forward as to our role at the National Academy of Social Prescribing. We were set up in 2019 by the Secretary of State for Health and Social Care to support the resource around social prescribing, training for social prescribing link workers, as well as collaborating with the voluntary sector to make this possible in terms of how the funding and the activities will be working. So what have we achieved in England so far? Well, over the past few years, we are very fortunate to say that the government has taken an overall national investment policy, and they've recruited 3,660 social prescribing link workers to this date. That is one for every single GP practice around the UK. So it's now universal wherever you may go to your family practitioner or to your local emergency department as well. We've had over 2.9 million patient referrals and over £500 million investment since 2019, and a commitment from the government to triple those numbers over the next 15 years. And I'll show you why they are so keen lately. It all has to do with the evidence, of course. It was also recognized as a simple tool for tackling loneliness and isolation, and it was part of the government's loneliness strategy. As you know, in the UK, we have a Minister for Loneliness and Isolation, and they are very, very big on practical solutions, and social prescribing was illustrated as one. In 2020, we wanted to make sure that the evidence is what drives this work forward. So we put together what is called an evidence collaborative, made out of the largest universities in the UK and academic partners from them. And we started doing evidence reviews, which you'll be able to find on the website. I wish I could go into every single one of them, but each and every single one of you, one size does not fit all. Some of you will be more interested in the impact on the human being, the impact on the physical activity, return on investment. Certainly for the government, it was return on investment, and I'll get to that in a second. But there's various elements of evidence in there that you can have a look at in your own time, including social prescribing for children, young people, the elderly, and so on and so forth. And I guess just to remind people that social prescribing is from cradle to grave. It doesn't it has no age. It's for young people, it's for the elderly, and it doesn't have to go via hospitals. Even self-referral is acceptable. Even a neighbor can refer their neighbor, and so on and so forth. I've just given an example of how I work in hospital with that. In terms of its impact, it's frankly mind-blowing. The studies that you find on PubMed report between 20 to 40% reduction in GP appointments in England for those areas where social prescribing has been implemented, and a 15 to 25% reduction in emergency and unplanned hospital care. This is associated with deprescribing, reducing the amount of unnecessary pills that people are prescribed, because for once, we're no longer giving them a pill and telling them, well, just come back in 2 weeks' time if it doesn't go away, and then they come back, they still have a problem because we haven't actually addressed what truly matters to them. So for once, we stopped seeing those readmissions and representations, and we were able to decrease the amount of pills that people are on. And quite a modest representation here of the financial return. For every pound or for every dollar, I would say $4 or $5 back. For every pound, three pounds back in the UK. In there, and of course the impact that it has on people in terms of patient activation and improving their overall well-being. If anyone's keen and is coming at it from a more healthcare angle, you can also find the full report on the impact of social prescribing on health services on our website as well. And I do recommend it. It has various areas in England flagged with the studies that have been performed in there and the evidence of how this helps. And if I was to, I always say this during presentations, but if I was to have a pill and present to you today a pill that decreases admissions by 20 to 40%, I believe you'd give me a Nobel Prize for that, but it's not as fashionable as a pill. So I think we just have to hype social prescribing up a bit more than it is at the moment. And the final element that I wanted to go in is this idea of cross-sectoral collaboration, which has allowed us to embed social prescribing as national policy. I come from healthcare, but I'm actually a big advocate that social prescribing sits within the community. And this is what's new about it. There's nothing really new about social prescribing because good organizations and good charities and good voluntary sector have been doing this for a long, long time. So what is it that is new? Is it just the brand? Well, I believe that what's new is that social prescribing is the glue between healthcare and the community. For once, they're not working in silos. For once, we understand that health is different from healthcare, and that we all play a role in health creation and how we collaborate with partners around the nation. And so this is an example of how we started working with our local museums, with our local cinemas to provide free tickets to elderly who are lonely, perhaps to do a gardening class, or what with Manchester United or Arsenal Club to give their stadium for activities that involve physical activity in the elderly and so on and so forth. So we recognize that health needs to be democratized, and it's not about healthcare, but about health. And these are two completely different words. And the idea that the sector can come together, and although they may not be funding, some of those charities and national organizations would be able to chip in with staff, with the stadium, with a museum, with resource, and I would be able to send some of my patients to some of those activities if they struggle, and we understand that there's more that plays a role in health in there. And I just quickly wanted to showcase, and you'll see Kate and some of the colleagues on this webinar, on this map, but we love learning from each other. We believe that in England we have one recipe for fish and chips, but each and every single country out there will have their own recipe for fish and chips and how social prescribing is being delivered and developed. And so if you'd like to find out more about countries around the world and how they operate, you'll find the case studies in here. And I will now reach the end of my presentation, and I'd love to leave you with this. This is what people imagine health to be. But actually, in essence, this is what health is. It's a site for repairs. So hospitals are for repairs, and this is where health and good health happens. It's in the local community and in our local homes. Thank you very much, and I look forward to our conversation.
Thank you so much, Bogdan. Fantastic beginning. There are already some wonderful questions coming through the chat, which we're going to return to at the end of our conversation, or at least the catalyst to the conversation. So for now, I'm going to pass it over to you, Dr. Kate Mulligan.
Hi, can you see my screen okay? Great. Thank you so much, Nisha and Jill and Bogdan and all of you for being here today. I am really pleased to be joining you from Toronto, Canada. So Toronto is on Dish with One Spoon Wampum Belt territory, and here's a picture of the Dish with One Spoon Wampum Belt. This is a pre-colonial treaty that required everyone across nations to take care of one another and to share and take care of the land and resources in the Great Lakes region. And so today, Toronto is home to First Nations, Inuit, and Métis people from across many nations and Indigenous people from around the world. And so I'm very grateful to be working from this land. And I think that this cross-border treaty at a time of geopolitical change is a good reminder of our relatedness. And so I'm also deeply indebted to and thankful to Indigenous health leaders here in Canada and around the world who have long led the way on holistic and relationships focused and culturally based approaches to health and well-being. I want to situate social prescribing a little bit differently, not just in the context of community and health, but also of the need to have strong local social infrastructure. That means that, in all the time, but particularly in times of crisis, local communities that have, strong schools, good community organizations, public access to parks and libraries, and so on, are healthier, are more equitable, and they're more resilient than those without. And we really saw that through the pandemic period, for example, where those that had good pre-existing local relationships and strengths had a lot more going for them and were more ready to deal with big changes that came along. And this is still true. So social prescribing, as Bogdan mentioned, is a bit like the glue. It can systematically link assets, engagement, and connectivity to strengthen that local social infrastructure so that we have strong civic assets, spaces and places. We have strong community organizations that bring people together, and that we have good digital and physical connections from public transport to digital access. So this includes arts and culture. And this is something that's been going on in many countries around the world for a long time. Prescriptions to art galleries, prescriptions to cultural activities, food, performing arts, you name it. And so this Montreal example on the left was from, I think, 2016. And then this most recent example is from just last week, a prescription at the Vancouver Art Gallery linking arts and health and nature. So a collaboration between the British Columbia Parks Foundation's Parks Prescription Program and the Vancouver Art Gallery. It also includes things like, as I mentioned, public spaces. So this is a really cool example in Toronto. It is a reclaimed public space under an elevated highway that has been reclaimed for people and for community. And last summer, they had a whole arts-informed, arts-programmed season called the Soft Season, about trying to combat loneliness and hardness and barriers separating people. And we did health analysis and found that it was a place where people did feel safety, they did feel belonging, they did feel a sense of health and well-being, and that the things that made a difference for them were very simple. Things like benches, a little bit of greenery, and some art around was enough to make people feel that they could stay and that they were welcome. So as Bogdan mentioned, social prescribing is a way of flipping the script from that biomedical lens about what's the matter with you to a focus on what matters to you. And in so doing, it also reminds you that you matter. And in current approaches to and access to healthcare, whether it's in the UK, in Canada, in the US, or many other countries around the world, that's not something we feel very often. We often feel rushed through and unheard in our experiences with healthcare. So focusing on what matters to you is a one way of foregrounding health promotion. And Health Promotion 101 is helping people take more control over their health and the conditions for their health and well-being. And so that involves something called self-determination, which has a number of different components that we really try to focus on in social prescribing. So that's autonomy, or the ability to make the decisions for yourself. You decide what social prescriptions matter to you. Competence, being reminded that you can do something, and arts participation is a really good way to do that. You know, taking control again, making a piece of art, having some agency in the world reminds us of what we're capable of individually and collectively. Relatedness or belonging, I think it used to be a very difficult sell to tell people that social connectedness was a determinant of health. Not so anymore. We know that it's really important to be around other people. We are relational creatures. That's part of our biology. And then the last one is beneficence, or the ability to give back. And whether that's sharing space with someone else, becoming a volunteer, or sharing what you've done or made or created, those are ways that we can give back to others. And what we find in our research about social prescribing is those are the people who show the biggest improvements in their in their sense of health and well-being. So that they have gone from perceiving themselves as someone with deficits or a recipient of care to someone with strengths and something to offer. And that cognitive shift is really important for the participants, but also for those involved in the healthcare and social care systems, to remind us that we all have something to give. So across Canada, we've developed a reputation around the world as being strong on ensuring health equity in social prescribing. So we have a number of programs that really help us focus on the health and well-being and agency and voices of specific populations, whether that's older adults, students and their mental health on post-secondary campuses, caregivers, Black-led health programs, as well as healthcare providers. So, for example, with Healthcare Excellence Canada, we're about to launch a big program for community paramedics to incorporate social prescribing into their work. And there has been similar work underway with pharmacists and with primary care, and also in hospitals. So lots of different healthcare settings where this can happen. Just before getting on the call today, we were talking about social prescribing for children. So here are a few pictures from the Vanier Pediatric Hub in Ottawa, which is a bilingual center, which is why some of these captions here are in French. But it's a way for children from a very underserved community in Ottawa to access things that help address their three houses: their house of worries, their house of good things, and their house of dreams. And that helps them to talk about what's important to them and what matters to them. So you can see prescriptions that involve dance, that involve drawing and painting, that involve being in nature. And so even though Ottawa is one of the greenest cities in the world, this is a small community in which it's very difficult for students to actually get out in nature, and kids. And then lastly, they're up in the top here just talking about they learned a lot and made friends. And so this is something happening for children and youth. If you go to our website, which is socialprescribing.ca, you can find all kinds of evidence that we've been pulling together about the effects of social prescribing. I wanted to share this one in particular because it's a very cool evidence and gap map of evidence from all over the world. And if you actually go into it, you can click on the different circles to actually access the primary studies yourselves. And then you can see where do we have lots of evidence and where is it relatively high quality and where do we have more work to do. And there are some specific considerations around arts and culture and well-being as part of this, in addition to outcomes all the way from processes and individuals to community level outcomes and policy. We also have done some economic modeling about the social return on investment. So like Bogdan have a similar result, $4.43 return on every dollar invested in social prescribing. Although this says in Canada, we actually use global data. So this is something that should be applicable in many contexts around the world. And the benefits come not only in reduced healthcare system costs, but also improved well-being and increased social and economic participation. We've got lots of fact sheets that you can use. And again, they mention Canada, but they're not that Canada specific. So you're welcome to have a look and see what might be of interest and value to you. We continue to grow those fact sheets. And I'll just mention that this is really, really growing across our country. So just a couple of weeks ago, I was on The Social, which is like Canadian version of The View, sort of, talk show. I was invited to write about social prescribing for one of our biggest public affairs magazines. And I think the part that is of real interest to me when we're thinking about, again, strengthening social infrastructure is that we're starting to see this being pulled into health systems across the country. So we went from a single pilot about social prescribing in 2018, 2019, to now seeing it happen in every province across the country, and systematized in at least one province in British Columbia, where they've got hundreds of link workers now funded by the provincial government. And in Canada, provincial governments are the ones that are, for the most part, in charge of healthcare. But you can see that it's being integrated into things like a vision to transform public health in Canada, social determinants of health work at provincial levels, thinking about inequalities in mental health and well-being. As well, I'm on the technical committee for the Health Standards Organization, which is going to set the bar for primary healthcare and is including social prescribing. The Canadian Intergovernmental Conference Secretariat on Arts, Culture, and Heritage that brings together all the federal, provincial, and territorial ministers is very interested in social prescribing. And the Canadian Institutes for Health Research has brought this into a number of their best brains exchanges, bringing people together to talk about it. And so I'll just end by saying, I hope we can continue to build strong social infrastructure in local areas in ways that we do have some control over in times when things often feel out of our control. And so I just wanted to point to this sculpture placed at the border between our countries, a piece of art to invite people into conversation and dialogue across borders. Let's keep that conversation going. Thanks so much.
Thank you so much, Kate. All right. And again, very active in the chat. Thank you so much for the engagement. There's clearly a lot of interest and for good reason. I'm going to pass this over now to you, Jill. Sonke, thank you so much.
Thank you, Nisha. And thank you so much, Bogdan and Kate. Really exciting overviews of what's happening in Canada and the US. I'm going to jump in and give us a little bit of context for what's happening here in the United States. We have a very different landscape around social prescribing and arts prescribing in the US. Notably that those things are yet separate and distinct in the United States. So in the US, there's a long history of social prescribing, decades, across which the term social prescribing has been used, but to describe programs that are coming from Medicaid, Medicare, that fund interventions for social determinants of health, very specifically basic needs like food, housing, and transportation. So social prescribing has been around a long time in that way in the United States. What we're seeing now in the US is a huge surge around social prescribing in the sort of global model that you've heard about this morning. In the UK, for instance, social prescribing, the National Academy of Social Prescribing that Bogdan talked about, describes 5 types of social prescribing: advice and information, so prescriptions that provide advice and information like social determinants of health-oriented needs, arts and culture, heritage, nature, and physical activity. So as Kate described as well, there's this social prescribing arena in which different things are the prescriptions, are prescribed, including arts and culture. But in the US, we don't yet have one thing in that way, one system, one orientation. What we're seeing rather is social prescribing oriented in the ways I've described through Medicaid and Medicare. We're also seeing a lot of energy and a lot of growth around arts and cultural prescribing and around nature prescribing. And so we have a long way to go in the United States before we have sort of structural or systematized social prescribing that is inclusive of all of these different types of prescriptions. And so there's a lot of growth happening, a lot of innovation. As you see on the slide, the Federal Reserve Bank is leading efforts to explore the missing market, to look at what markets for social prescribing might be like in the United States. There's a lot of dialogue about how social prescribing, in the ways that you've heard already, can be a part of our health system and public health system to enable greater wellness and prevention, particularly for those who are or underinsured. And in the US, of course, we are both a public and private healthcare system, and globally, more of the 40 plus nations that where we see social prescribing have public healthcare systems. So there's a lot of important innovation and activity happening in the United States right now to demonstrate how social prescribing can happen in privatized and in public private health systems. We also recognize, as you've heard today, that social prescribing and arts prescribing have the potential to really contribute to health equity. And in the United States, there's a lot of exploration around how social prescribing and arts prescribing can be accomplished through systems alignment and resource allocation. So we don't yet have return on investment data, those sorts of data, but there's more innovation and exploration happening around what the systems and what the structures for social prescribing may be as it's scaled in the United States. So I'm going to focus this morning on research that we're undertaking in the Arts Lab focused on social prescribing. So Daisy Fancourt at University College London and I co-direct the Arts Lab, which, as Nisha mentioned, is a National Endowment for the Arts Research Lab. We're focused on, we have been in operation, we're in our 5th year now, and we are focused on large cohort longitudinal studies that look at relationships between the arts and health. And we have, in the past few years, moved very strongly into looking at social prescribing and doing research on social prescribing. And specifically, in this phase of our work, which we're just completing, we've conducted 23 case studies on social prescribing programs and pilots in the US, and I'm going to talk about those. We've just completed an implementation science study looking at enablers and barriers and structures and how these programs are built and how they're working, what their challenges are. We've developed a set of key common outcomes for social prescribing research in the United States to try to help advance the evidence and research around social prescribing and to enable evidence synthesis, which is so important to evidence-based practice and policy and investment. We've also created a core outcome set for arts-based approaches to social isolation. So I'm going to give you some sneak peeks of this research this morning. So the 23 programs and pilots that we have just documented are located across the United States. You can see prevalence in the Northeast and in Florida. And these programs are really interesting. As you can see, they're designed and run mostly by arts and health organizations, and they include a pretty wide range of activities. Someone asked about animal programs. We see one program, one of the 23 case studies is a social prescribing program where a zoo is the partner and zoo-based activities are the activities. Interestingly, of these 23 programs, most included arts prescribing, and most really are arts on prescription or arts prescribing programs. In almost all of those programs, referrals are coming out of the healthcare system through healthcare partners and professionals. And at this point, we're seeing that funding is coming from public organizations and philanthropy, foundations, grants, and in 2 instances, through a health insurance company. So Blue Cross Blue Shield is a partner in pilots in New Jersey and in Dallas, Texas, which is really exciting and encouraging in the US. And I'll just mention that I'm going to share enablers and barriers from our implementation science study as well. And you're going to see some similarities. So I'll ask you just to sort of take note of similarities across these 2 as I share these. And this is so much in alignment with what Bogdan and Kate talked about. Trust, the importance of relationships and trust in social prescribing is very much reflected in our US programs. As we learned through the case studies, that stakeholder relationships, the partnerships across sectors that enable social prescribing and arts prescribing are really important. Staffing, having adequate staffing is really important. Activities that align with participants' health and well-being goals is key. And here, the next one is where the link worker role is. In the United States, we don't have a norm around a role called link worker. We have a range of roles that are serving that purpose. So in our studies, we refer to a program point person or a caring point person who plays that link worker role. Sometimes that person is a link worker or a patient navigator or a community health worker, so a social worker. We see a range of roles there, but we also note that that's a really, really important role in the ways that Kate and Bogdan have described. Technology is really enabling. I know Chris Appleton from Art Pharmacy is here. That is an incredibly important and exciting innovation in the field in the United States as a platform to enable social prescribing and arts prescribing in particular. And the notion of welcome is really, really important. Barriers include lack of understanding. This came up again and again, that not only do people in the arts and health and other involved sectors not understand what social prescribing is, but the general public also does not yet understand this as a concept in the United States. And difficulties using technologies, platforms that are being used was noted as a barrier, and practical things like childcare and transportation, how people get themselves to be able to participate in these programs. Those practical considerations are really important. So in our implementation study, we took a deeper dive into 9 of the 23 programs. We had 34 participants involved in this study, which included very long and comprehensive surveys and interviews. And we were really delighted that 14 of those were program participants, 11 were program staff members, and 9 were the managers of these programs. So we had a really beautiful array of perspectives that were brought to bear in these studies. And very much in alignment with our case studies, and that methodology also included surveys and interviews where we were hearing from stakeholders across those programs. That caring point person, link worker role was critically important. Cross-sector collaboration and teamwork. And Kate talks so much about the importance of relationships across the whole spectrum of social prescribing, and we're certainly seeing this here. And again, we see that alignment with participant interests and goals, activities that cultivate social connection. So it's not just about recommending you should paint on your own, right? Or do something creative at home, which we know can also have health benefits, but the social dimension of social prescribing is critically important. Accessibility and convenience. And again, welcomeness, and inclusivity. It doesn't help for a healthcare system to partner with a performing arts center where the people who are meant to be served, those who are uninsured and don't have as much access to wellness and prevention, don't feel welcome in those institutions. So we heard a lot about lack of welcomeness in larger arts and cultural institutions and the importance of hyper-local resources being brought to bear and welcomeness and inclusivity being a part of that landscape. Again, barriers, understanding, number one. So this notion, this concept needs to be socialized in the United States in both professional and general public circles. Inadequate funding and staffing support. Often people are piloting with existing staff who are trying to squeeze this into other areas of their responsibilities, and that's a big challenge. And lack of standardized processes, tools, and terminology. So again, some clear alignment across these studies. We also did a mapping review of social prescribing outcomes in the US as a part of developing our key common outcomes. This paper is available, so you can see the 347 outcomes that we mapped from a total of 87 articles from around the world. So we were looking at what outcomes were studied and how often. And so you can see in this model, the size of the circle represents how often that particular category of outcomes is studied. So all of this work, mapping, recommending outcome studies through key common outcomes and core outcomes, is a way of advancing evidence synthesis in the field, as I mentioned before. It's a way of saying, hey, folks, if you're studying stuff, please try to study these more common outcomes so that we can build the potential for evidence synthesis to inform practice and policy and investment in a more grounded and evidence-based way. It's also important to note here that 347 outcomes is a lot. And in a very important way, that represents a breadth of outcomes that reflects the breadth of programming that's happening. And it's really important that we not limit the number of outcomes that are studied, because social prescribing does a lot of different things, and we also need to study a lot of different things. But if we can focus on including key common outcomes and core outcomes, that will also help us advance this evidence base. So just a sneak peek, this article is under review, but you can see what rose to the top in the United States. Well-being, social connection, coping and resilience, social determinants, loneliness, health self-efficacy, belonging, condition management, user experience, and physical activity at the patient level. And at the system level, very much in alignment with what you heard from Kate and Bogdan, research that's coming out of the UK, Canada, and globally, health equity, return on investment, savings to our healthcare systems and system utilization. We also saw attention around workforce outcomes, how these programs are helping with staff satisfaction, burnout, sense of accomplishment and effectiveness of the work of healthcare providers, which is very important, and those primary care visits, which you heard about earlier as well. Lastly, I want to give you a little sneak peek of this research, which is under review. Daisy Fancourt and Randy Cohen from Americans for the Arts and I partnered on this, and Randy and I wrote a question that was included in an Americans for the Arts survey recently. There were 3,062 respondents, and the question to this general sample of Americans was, if your doctor wrote you a prescription to participate in the arts as a means of improving your physical or mental health with those examples, how likely are you to follow their recommendation? And interestingly, 76% of Americans said they would be likely or very likely to follow that recommendation if they were given a prescription. And this article that's under review now really drills down into the demographics of that, what age groups, what genders, what other demographics, even what political affiliations are leaning into social prescribing. So this is really interesting research, but very encouraging in terms of people's understanding that this would be something that would be useful to their health. So we're very optimistic in the United States that there is a readiness Kate and Bogdan described all of the system level reasons why social prescribing is interesting and effective, right? And we're also seeing an interesting readiness among the general public. So we're really looking forward to more innovation and organization in this space. And I just want to close by sharing a few more resources. Tasha Golden, the state of Massachusetts, the Center for Arts and Medicine collaborated to create this Arts on Prescription field guide for US communities. And that QR code will take you to that resource. You can also find through our social media and website in the Center for Arts and Medicine a beautiful report. Both Kate and Bogdan were involved in a social prescribing design sprint that happened at Harvard University. And lastly, next week, April 24, our case study report in Lancet Public Health is scheduled to be released. And as that is released, we will also release our full report of the 23 US case studies. So watch our social media, watch our website for those resources to be released next week as well. So thank you. Thank you, everyone. Thank you, Nisha, again for hosting us.
Thank you so much, Jill. I can see, I mean, there's a lot of excitement in the conversation that's happening to the side here in the chat, and many questions that have come forward as well that have to do with implementation and impact, uptake, costs. So I'm going to just pick out one for us to start off with, which maybe goes back to the fact that Bogdan, as a physician, you've been championing this work, and it'd be interesting to know. I mean, you've also said, listen, this isn't only about what physicians prescribe, it's also what you might prescribe yourself, right? Which is a really important message to underline. That said, what are your thoughts? And this is to the whole group, really a question to begin with, your thoughts around what can facilitate the uptake further and the role of physician champions in that. There's a question specific to that. So maybe we'll just pass it over to Bogdan, and then I'll pass it over to you, Jill, for some of the other questions that are coming forward to continue with our Q&A.
Thank you, Nisha.
Thank you very much, Nisha. It's one of the questions that we've been pondering about. And let me just start by saying that we've had huge pushback in the beginning because medical school teaches our physicians in an algorithmic way. It teaches people to deliver care that is based on if X, then Y. If you're high blood pressure, then give this pill. If your blood sugar is high, then give this type of insulin, and so on and so forth. If loneliness and isolation, I'm not sure what pill I'm going to prescribe for that, right? And so this algorithmic way of one pill for every ill doesn't really do justice to the fact that we're all unique and the fact that all of us have an element that matters to us. And so we've had huge pushback in the beginning. However, you may see it in the title as well, social prescribing. Many people ask us, why did you name it social prescribing? Isn't it medicalizing things that shouldn't be medical? Correct. But it's actually acted as a massive Trojan horse for those physicians and those doctors who always wanted to prescribe something. Well, now you can prescribe a gardening class. Now you can prescribe a music therapy session for your patients rather than a pill that would actually cause more harm than good in certain circumstances and instances. So we kind of fought fire with fire. So the terminology was very important. The fact that it was in a way put on the same level as a medical intervention and seen as important because we talk about the biopsychosocial model. And in the UK, we've done work over the past 10 years to ensure that social prescribing is at the heart of the university curricula. And I can confirm that now it is part of every single medical school, every single one of the 44 medical schools in the UK, but also part of the multidisciplinary careers such as nursing, midwifery, pharmacy, occupational therapy, and so on and so forth. And we have a national clinical engagement strategy, and we work with physicians to ensure its uptake. But I think the one thing that I think has made physicians to be more involved is to realize that we're not asking them to prescribe anything. We're simply asking them to say they may not be able to help, but be aware that the local community is a resource that they can tap into. And yes, they can deal with the biomedical side, but if they don't have any time, they could just kindly support that individual in the local community and work with the voluntary sector to support that person in the longer run. And actually, I think, Jill, you mentioned this, doctors have started enjoying their work a bit more, because we used to have this moral injury of someone being sent back to what made them sick in the first place. And so now finally we have a tool, a practical tool that could support some of those individuals with social and psychological issues that we may have not been able to sort with pills and with procedures.
Thank you, Bogdan. That is so important. I want to just add one thing, because this question raises something that's on my mind a lot around social prescribing. And that's that I don't think it's an end point. You know, the idea of people needing to go through the healthcare system to get to these social supports in their communities is not actually the way we design it to work, right? I think social prescribing is an intermediary toward all of us as the general public, understanding that these resources in our communities are health resources. In the Arts Lab and in the field of arts and health, we talk so much about arts participation as a health behavior, right? But the general public doesn't yet fully recognize that, like exercise, eating well, wearing seatbelts, participating in arts and culture, and other things that are prescribed through social prescribing are health behaviors. So I think social prescribing is a really important enabler of that understanding. And ultimately, it will provide access to arts, culture, other local resources for people who are approaching and coming to the healthcare system. But it also needs to be general understanding and part of our norms, so that people can get themselves directly to those arts and culture and other health resources in their communities. So there's a lot of work to be done around resourcing that, right? How does social prescribing as a system help contribute to more resourcing for those activities and communities, so people can access through the health system through social prescribing, or access directly of their own accord? So I think a lot about that. Kate, I think you're ready to chime in here.
I have so many responses, and I'm loving seeing all of the engagement in the chat and talking again with the two of you, because I miss it. It's always great to connect. I have a few comments. One about the physician champions and the need for champions. We've actually found in our research that this is important in every context. So not just physician champions, but community paramedic champions, pharmacy champions, nursing champions, community-based champions. Each community involved in social prescribing needs to see itself represented, needs to see evidence that matters to them. And this also includes the different kinds of communities who'll be participating in social prescribing. And certainly across huge and diverse countries like ours, the work is very context specific. And so, it's really asset-based community development. But if we called it that, we wouldn't be meeting the healthcare folks where they are. And so, as Bogdan said, social prescribing is a term that helps us make a bridge between people who have different languages, different sets of evidence, different strengths, and different needs. So, that's, starting with what's strong here rather than what's wrong here, and continuing to build in positive ways moving forward. I also wanted to share one thing too that's I think might be interesting in the US context, and it has been here, and that is the tension between spreading social prescribing and scaling social prescribing. So it's not the same thing. And what we have found is that essential piece of co-production with people, relationships, for working on what matters to them, can be at risk if there's just top-down mandate or implementation. And we saw this in the UK, where some places and practices were very ready and had cultures and institutions of support and readiness to do social prescribing safely and well. Other places weren't. And that does, as Jill has mentioned, sometimes can put people at risk of more harm. And so what we're seeing so far in Canada is we're not in a rush to do a giant national level implementation, but we're nurturing the conditions and ecosystems in which local innovation can really thrive. And when we're ready, we can negotiate for some of the resources and supports that might be needed from some of those higher levels where policy barriers or resourcing barriers may exist. I'm going to say something a bit provocative, though. From an abundance mindset, we already have almost everything we need to do social prescribing right now. And although it would be nice, and we won't say no to lots more resources and support and interest in funding, we can repurpose much of what we currently do in our, depending on what the policy structures and everything looks like in our own context. But much of what we're seeing here in Canada is, taking a nurse position and making that person a link worker, hiring a peer community health worker and rebuilding community local supports in a way that is accessible and capacity building, right? So there are ways that we can do that. And we're really, really leaning into that now so that we can maintain community ownership and community control over something that's really important. I have lots more to say, but I'll stop there for now. Thank you.
Thank you, Kate. So many incredibly important points. And yes, in the United States, we know we have so much wasted spending and ineffective spending in our healthcare system. So that notion of resource reallocation is really important. I agree wholeheartedly with you, and there's so much work to be done there to explore those possibilities. Bogdan, I want to turn to you now. There's questions in the chat about the business model, the financial models for social prescribing. So I think this is a great segue there. Could you talk about that from the UK perspective? Kate, I'd love to hear from you. Let's have a little bit of dialogue around what the business model or the financial model for social prescribing is in your countries or elsewhere.
Absolutely. Thank you, Jill. And I also want to touch maybe for 20 seconds on this element of provision towards individuals who may not be able to afford some of these activities, because I think it's still part of the financial case. And there's a great point on the chat that I put a thumbs up on, which makes the case for that. And I'd love to comment on that. So I think just in simple terms, in England, for example, and of course, once again, we were quite fortunate that the government took this as national agenda. So the way in which social prescribing works in England is that the funding comes directly from the government, and it goes via the Department of Health towards social prescribing at a national level. Now that's very lucky, and we didn't start from there. Obviously, you're now seeing the product of lobbying and a huge pushing through pilots and evidence and showcasing of what social prescribing can do. So from 2012 to 2019, we struggled to make the case for it. In 2019, the government said, it sounds good, let's do it. And so the way it works at the moment is that the Department of Health has hired and recruits the social prescribing link workers with support and training from ourselves, but the funding comes directly from the Department of Health, but it's only used for the social prescribing link worker training and payment of their annual salary. That's very important. So what does that mean? Well, it means the activity itself is not actually paid for by the government. So then who picks up the bill? Well, this is a huge debate and a matter of lots of controversy in the UK as well, because the voluntary sector and the community sector ends up actually providing some of the funding for the community activities. And this is where we as the National Academy of Social Prescribing have started becoming a bit more proactive in developing shared investment funds, working with various organizations, with national charities to develop shared investment funds to be able to deliver some of those activities, because the government would only pay for the social prescribing link worker, i.e. the person that's been recruited via healthcare. In the past, social prescribing was funded via philanthropic organizations. The pilot studies were done via different businesses, but at a national scale, at present, that's what it looks like in England. And I think it's very important to go back to that element of do only the rich have access to it? Actually, completely not the case. In fact, in England, we see social prescribing as tackling health inequalities and being able to support those who actually need it the most. The individuals who would never say to me they're lonely, individuals who would have financial concerns. In fact, 50% of all of our referrals in England are for housing and financial debt. And so you may wonder, well, how does the social prescriber link worker help them? Well, they once again build rapport with them. They help them apply for benefits. They use perhaps some of the language that they may not be able to use, or they may not have even access to English language, or not able to navigate that benefit system. And they would be able to help that person find a job, apply to benefits, and perhaps apply to get a house if they needed such a place, and so on and so forth. And they work with a social worker. They're not one and the same. There are countries around the world in which those two roles are the same, but not in England. They are completely different. And so the community funds some of these activities through various shared investment models, and you can find more. I'll put a link in the description in there. But once again, we are big believers that access is very important, and actually in the hierarchy of needs, some individuals will not want the art therapy, they'll want the financial advice or the debt or the housing support first, and then they'll go into some of the other activities in there. Not to say that art wouldn't be beneficial to them either, but then there are a few things that need to be ironed out first before then.
Thank you, Bogdan. Kate, would you add to that?
I will add that one of the benefits of not being first out of the gate with social prescribing is learning a lot from how other folks are doing it. So we've learned a lot from Bogdan and from peers around the world and their experiences with social prescribing. One of the critiques that came up early on in the UK was that there's not enough evidence or evaluation. That they were just, starting with implementation. And of course, that's going to be true for any innovation. So it's a bit of a spurious comment, but we did learn that it's important. It's important to do evaluation that's meaningful to local people and to systems and funders and decision makers. So one of the reasons why I really like social prescribing, even though we don't want to over-medicalize the use of community services and participation in our lives, is that we can finally do what I call precision community health. And so we can see what happens when an individual is referred to a community service. We can track that in the electronic medical record. We can see whether they followed through. We can do follow up, and we can see what happened to their experiences of healthcare, what happened to their health outcomes, and what happened to their use of health services. And we're going to see, we've already seen lots of evaluation improvements in all those areas. Some people will use healthcare more because they weren't taking care of themselves. Others will use it less because their needs are being addressed elsewhere, and they weren't really medical needs to begin with, but they were starting to have medical consequences, or people didn't know where else to turn, right? Having lost a lot of the social infrastructure that used to keep us going as communities. So I think that referral and tracking, and as I think Jill and Bogdan have both mentioned, the supportive relationship of a link worker who helps you to follow through, maybe goes with you to the first few swimming lessons, helps you to make friends, figures out the transportation, a lot of those kinds of things. That support can help a lot too. And then again, it's going to be tailored to working in a way that you need, but we'll have an evidence base that's meaningful to decision makers. And so I call this approach a learning health policy systems approach, whereby policy decision makers and funders, implementers and on-the-ground people and participants all come together to decide how they're going to do evaluation, what matters to them locally, and how they're going to use that for improving quality and sharing. And when we're all involved in that and co-invested in it, then we're getting the results that are actually going to help drive better decisions and better funding and better resourcing for this kind of work. And it'll help us move the funding more upstream, which is one of the big goals of this.
Beautiful. Thank you, Kate. I'm going to ask kind of a two-part question, and this comes from some of the questions that are in the chat pertaining to equity. Could you each talk a little bit about examples that you've seen in programming that are really effectively addressing equity and health equity? Or could you talk a little bit about what you think are the biggest pitfalls or cautions around equity and health equity in relation to social prescribing?
Get started. Yeah. So I think there's a certain danger. I'll start with the second part of your question, Joe. There's a certain danger to make it seem as if social prescribing will solve everything, and it's the solution to inequality, and that it can tackle every single one of the social determinants of health. And sadly, there's of course a lot of systemic issues at play. Politics are a social determinant of health. I believe I don't have to mention that. I'm sure everybody will be aware of that. And so, for example, when somebody does apply, for example, for benefits and are trying to seek for support with their financial debt and so on and so forth in England, there's no guarantee that will be a success. Yes, they have a higher chance now of knowing what's available to them, and some of them may not have the language requirement to even know what's available to them, but nobody promises them that they will get that support support anyway. And so I think it's a caveat there that I like to just put, because quite often newspapers in England have put, social prescribing can save the NHS, or there's big titles, and then there's a lot of backlash that we get from there. For us, it's a simple tool that enables us to connect individuals to wider resources, and of course there's wider stakes at play in there as well. I think the best example that I have is both from my emergency department work, but also more concrete example from Bromley by Bow, which used to be one of the areas in London with the highest crime rate, gunshots, knife wounds, but also one of the most impoverished areas in London. Very high proportion of Bangladeshi individuals. Fascinating model. The link worker there is a Bangladeshi, was at the time, it was just one of them in 2012. There's a Bangladeshi woman who spoke Bangla and who went from door to door and knocking on people's doors and inviting them on the grounds of the community center, which also happened to have a neighboring healthcare center. And she increased the screening uptake for cervical cancer. And there was this huge evaluation around how they decreased mortality rate in individuals who would have never actually presented because of cultural norms would have not allowed them to do so. And then together, that same lady, who was again the link worker, got the whole of the population to rebuild the community center. They stripped it out of CCTVs, and there was no more CCTVs in the whole center. People used to steal and rob that whole center. They got rid of all the CCTVs, and nobody's stolen anything since, because they built it with their own hands. And if you see that same community center now, I'll post the picture, maybe later I'll send it to Nisha for you to share. It's a vibrant community with a church on the ground, and it doesn't matter what faith that people are from. It's an interfaith a community group that gets together on a Sunday to have tea and coffee, and the community has been thriving incredibly well. And some of the people that this woman has reached, again, who would have never presented to the healthcare environment in the first place, they then wanted to help others. And there's this patient activation idea that then some of them became social prescriber link workers themselves. But this is why we are big believers that we voted against national training. We voted against a formal university degree for social prescribers. We wanted people who are from the local community, who speak the local language. You don't need an MBA to develop good community around. And so we voted against that at a national level. Yes, there are some training standards for link workers, but there is no formal university degree, and the training has to be done locally on the local demographics. I think that's the best example that I could give to your question.
Beautiful. Thank you, Bogdan. Kate?
Social prescribing is a midstream intervention. It's a mesoscale, community level intervention. And so it's not intended to be necessarily a giant macro scale intervention. While it supports individuals, it's really based at that community scale. And what we've seen over the last, in the post-war era, and especially the last 30 years, is a real hollowing out of that community level. So there's maintained investment in individual health, there's public policy work going on, but not as much happening at the community anymore. And so we need to fill that vacuum in a good way and be that connective tissue to revitalize that community scale piece of action. So yeah, social prescribing is not going to build more housing. But if we're measuring it well, we can demonstrate the impact of poor housing or lack of housing on health systems. And we can demonstrate in a really precise way the demand for housing, exactly where and for whom it's needed. And so those approaches, I think, are really important to really recognize that that's our niche, that's the scale at which there's a huge amount of need. And I'll say, as I mentioned, in Canada, there is a lot of work that's by and for specific populations, which is a good equity approach. And really the philosophy that not only is it nothing about us without us, but it should be by us for us. And so the leadership happens by and for community. That inclusion of community voice and leadership and support for that work is equity building work. It isn't to say that it always happens well, and we've had sort of mixed findings across Canada, and different contexts do this differently. So places where there already is good precondition for equity work, it happens in better ways. Other places, social prescribing is now being used as a bit more of a crisis support, because in those provinces, in Alberta, for example, which is had a long time conservative governments, the existing social safety net is not as strong as it once was. And so social prescribing is meeting some of those basic needs. Whereas here in Ontario, where I live, it's more often used to supplement supplement any support people get for their basic needs through social work and other professions. So equity is an ongoing dialogue, but centering the voices of participants and communities really has to be at the heart of it.
Beautiful. Thank you, Kate. Nisha, do we have time for one more question, or shall I hand it back to you?
Yes, you could take one more.
Okay, great. Just a quick question, Kate and Bogdan, for each of you to close. And this is a big one. There are a lot of things needed, right? A lot of opportunities for advancing this field of practice and policy and systems development around social prescribing. What do you think in your context or in a global context is needed most to really advance what we want and what we hope for social prescribing?
It's a great question to close with. Jill maybe sets the tone for the next webinar session as well, but I'll keep this very, very brief. From my perspective, two key things. First, focusing on what truly matters to someone, not my assumption of what I think matters to them, because I fell into this trap in the hospital many times to provide what I think is good for them. And then as they are to leave my clinic, they'll say, oh, by the way, doctor, actually, I have some 10 other problems that I never asked them about. So focusing on what truly matters to individuals is we talk about personalized medicine and drug targeted therapies. Well, in the same way, one size does not fit all in care in general as well. So that's very, very important. And the second, every single one of the 32 countries that I've supported in terms of social prescribing around the globe, it's always been about getting people around the table, cross and inter-sectoral collaboration, not working in silos, making sure that academics are at the same table with key stakeholders, political governments, with physicians, with local community sector, and not doing this work individually, but working together to solve this issue. Because once again, health is not healthcare. It's not the institutionalized way of delivering the field. Health is at the intersection of all of those elements, and we are all involved in health creation. That would be my takeaway.
Beautiful. Thank you, Bogdan. Kate?
I think my answers are going to be a bit philosophical. What we need is to shift our mindset from what's wrong with us to what's strong with us, and really start there, and shift our paradigm from what's the matter with us to we matter, and focusing on what matters to us. And those things in relationship, remembering that humanizing what we do is so much at the heart of social prescribing. Over the years, we've over-professionalized a lot of our work. We're hiding behind liability concerns, professional languages, feeling like we're not, citizens in our own lives that should be acting in community when we take our professional hats off or we leave our work for the day. We need to really take ownership of our collective well-being, be courageous, be willing to take those next steps, and just rehumanize and give ourselves permission to think as human beings in caring ways. And look around at all the support that there is. I think relying on each other. Those are the kinds of really simple, but I have found really meaningful and sustainable ways to do this work.
Beautiful, thank you. And I would just add from my perspective in the US context, I feel that we shouldn't leap too quickly or be too eager for the top down. You described the top down, bottom up sort of dichotomy, Kate. I think we shouldn't be too eager to sort of universalize or make national, because the hyper locality and the localness of social prescribing, I think, is incredibly important. And the United States is such a diverse and vast landscape, and our systems from locality to locality, even across the local to national spectrum, are so varied that I think we really need room and time for innovation and to see practice in action and to assess it. So I think research is incredibly important. Enabling research and enabling sharing of research and findings, so that really focusing on the bottom-up grassroots development at this point, and keeping those national eyes open at the same time, and keeping sort of priming that space, I think, is really important as well. This has been such a beautiful conversation. Thank you all for the great questions. We did not get to a fraction of them, but the chat is there. I assume Tessa will be able to include that with what people receive. Really rich dialogue there. Thank you all so much. Thank you, Nisha.
Thank you so much, Jill, Bogdan, Kate, and Tessa for your coordination in the background. Tessa's gone ahead and put a few links in the chat that will enable you to stay connected with us at the Jameel Arts and Health Lab, and to also provide your feedback on today's conversation and your ideas for future conversations. These are bridges in between the research that gets published and what we do with it, how we make use of it. That is one of the aims that we have in the Jameel Arts and Health Lab, and I know that it's something that each of my colleagues here is deeply committed to as well, so that we can see this work flourish and see the arts really well utilized as a global health resource, along with some of the other ideas that are part and parcel of social prescribing. So with that, I think I'm just taking a quick look here to see if there's one more announcement I'd like to share, which is that in addition to these monthly conversation series, we will be holding a series of events during the UN General Assembly Healing Arts Week, UNGA Healing Arts Week, and that will take place in New York, but there will also be some events online. So I'll invite you to stay close to our channels to find out more about that. We will be following up with a newsletter so you can get a recording as well as the links that were shared today. I call your attention to the UNGA Healing Arts Week because there is a call for proposals out, which is due May 17th. Should any of you be in a position to be able to come and engage in that week with us in New York. We've been highlighting UK, US, and Canadian examples today, but I'm also reminded of previous conversations here in this conversation series where we heard about that grassroots community building approach from India, from Armenia, from Singapore, and other countries. So the conversation continues. That's where we'll end. Thank you all so very much. Have a beautiful day.